We know that von Hippel-Lindau disease and von Hippel-Lindau syndrome is a genetic disease that predisposes to the development of kidney cancer. And we know that we see a lot of young people with kidney cancer, so they often ask us the question, are my family members at risk? Am I at risk? Do I have a genetic abnormality? And there's a recent article by Brian Such, who did this when he was at the NCI, who looked at hereditary kidney cancer and when we might want to start referring patients to genetic counseling in the setting of renal cell carcinoma. So Dan, what do you do at Duke, and how do you integrate a genetic counselor, and how do you build this into your practice?
Yeah, this is a great question because, kidney cancer, when you look at this, across the population, median age of diagnosis is about 65. And it's one of these classic kind of Gaussian curves. So when you go down, 20 years from that to average age around mid-40s, you're looking at probably just 3% or less of these kind of spontaneous kidney cancers. So, and if you look at the onset of these patients with hereditary kidney cancers, they range, from somewhere around kind of mid-30s to mid-40s. So this is the overlap area where these patients, although they're still, because spontaneous cancers are so much more common than the hereditary cancers, they still very well may be spontaneous cancers. The incidence of these hereditary cancers now is maybe as high as the spontaneous cancers in that age group. So one thing we don't want to miss is a hereditary cancer that maybe has sort of incomplete penetrance, that maybe they don't have all the cutaneous manifestations of Birt-Hogg-Duvay, but they've got the mutation, and they could be a founder mutation. You can't necessarily go by their history to say, oh no, there's no hereditary component here. So for those patients, that's where, at least at Duke, we have a hereditary cancer clinic. We'll refer them. We work very closely with the NCI. When there's tests or assays that we don't have, we'll send the blood up there.
So what's your trigger, Dan? What's the age of the patient? I mean, in the Such article was in the mid-40s.
Yeah, probably 45, somewhere like that.
Well, that's helpful. I mean, I actually think that it just reminds us that much of the progress in kidney cancer has been made on the back of understanding the hereditary disease. And that if we're going to make further progress, further insight into the hereditary disease will inform us about the questions to ask and answer in the sporadic forms. And the other article that I just want to just talk about, only because I think it's so critical to our daily practice, is, and this is for you, Brian, is an article that came out in Critical Reviews in Oncology Hematology by Thomas Schoeman, where he talks about drug interactions with targeted therapies. I mean, I can't imagine that any patient that you've seen doesn't come to your clinic being on a variety of other drugs for their hypertension, for their diabetes, for their inflammatory diseases. And there are drug-drug interactions with those drugs and the things that we want to start. So Brian, how do you manage that part of taking care of patients? I'm sure that maybe the pharmacist becomes an important part of your team.
Yeah, so we use Epic as our electronic medical record. So if we, as long as we have an accurate recording of their current medications, if we go to prescribe something new and there's an interaction, we'll get a little pop-up box. We also will just call our pharmacist, sort of outside of that sort of electronic, arrangement. And then, for people on clinical trials, obviously our nurse will sort of carefully go down, and trials will often have their own list of medications that are either prohibited or kind of on a watch list, if you will, and if you can switch it, then switch it. So it is very much, as we're starting somebody on a new therapy, it's one of the checklist items for us. I
mean, there was just a very nice article, I think it was in a recent JCO, that talked about the relationship of people that smoke and receive a TKI for kidney cancer, and how active smokers just do less well. So I think it's important for us to remember that the metabolism of these drugs are absolutely affected by the other things that people put in their bodies, and that we have to, in order to get the best outcome, we have to make sure that we understand the interactions that are taking place. Do you do that as well,
Sure.
Nizar?
We have our pharmacies in the clinic. We interact with them on a daily basis. I think in addition to the drugs that patients are taking as for their therapies, whether it's hypertension, diabetes, let's not forget also the stuff that they take over the counter.
The nutraceuticals.
That can also interact with what they're taking. And I
Well,
think,
how do you counsel patients? What do you say?
we tell them that we go over the list and we say that this may actually be harmful to your liver or your kidney, or that there is no data that this is safe to take in while you're taking your TKI. So I think this is important for patients to really know and tell their physicians that I am taking, or for the physicians and the nurse in the clinic to ask the patients about what they're taking. So I think the two main categories where we worry about the drug-to-drug interaction is with the CYP3A4, where the metabolism of these TKIs come in to play. And I think there are some drugs that are really good drugs for hypertension, but may not go well with sunitinib or pazopanib because of the QT interval. So I think these are things where the pharmacist is involved with our patient right from the beginning.
Yes, I think that from our panel's perspective, I would just implore those of you that are listening to this conversation to make sure that when you start ordering a new drug in kidney cancer, that you at least visit with the pharmacist or have the patient visit with the pharmacist, or a medical record system like Epic, or some other place where a review of the drugs will give them some pause about potential drug-drug interactions that may either cause more toxicity or even make the drugs that you're delivering less effective.